Okay, how are we using innovative technologies in treatment? Hopefully by the end of this, you guys will start to recognize some of the challenges that we have with delivering evidence-based care, because we have a great evidence base, but it's hard to do, right? This is something that we encounter every single day, and it's hard. And identify the role of innovative technologies in addressing some of these challenges. That doesn't mean all the challenges are gone, but it creates a path forward here. If I'm successful by the end of this, you guys will be able to do both of those. If I'm not successful, maybe one, we'll see. Just as a little bit of a background, because I know not everybody may kind of eat, sleep, and breathe OCD. When Jimmy was given the introduction, I was like, wow, I really need to stop writing papers and journaling and all that other stuff, and just play more video games. But we know anxiety disorders affect up to 20% of individuals across the lifespan, and I would contend that may be an underestimation of what we're actually seeing, because not everybody goes to the doctor to seek treatment for anxiety disorders. Obsessive compulsive disorder, prevalence studies go between 1% and 5%, but consistently around 2%. So these are conditions that a lot of us are seeing in the clinic on a day-to-day basis, particularly more so anxiety than OCD. What goes into these symptoms? For anxiety, in case you're more of a neuroscience person or a bench science researcher, anxiety is really characterized by 3 broad symptom domains. So you have these cognitions, these worry thoughts that are popping in your head, a lot of cognitive misappraisals. You know, did I walk out on the plank just right? You know, did I do all the things that Dr. McGuire told me to? And somebody might be ruminating on these things very much right now, or not. So there's a lot of cognitive misappraisals where we kind of have these fallacies of logic. Somatic symptoms. So these physiological responses to these anxiety triggers, you know, oftentimes in adults this might be tension headaches or muscle tension. In kids, you might have kids not wanting to go to school because their stomach's starting to hurt. And usually that's the first sign that kind of comes on up. And behavioral responses to these kind of fearful thoughts and kind of anxiety-provoking triggers, which is largely characterized by avoidance or, in some cases, oppositionality. You know, kids don't want to be afraid. Adults don't want to be afraid. Adults will avoid. Kids will potentially tantrum or avoid, which serves the same function. In OCD, we have obsessions, these intrusive thoughts that come in our head, and compulsive behaviors that we do to alleviate those thoughts. Similarly, patients might kind of seek out avoidance or seek out reassurance from their loved ones. Did I do this okay? Am I going to be fine? Or they may engage in ritualized avoidance where I'm just not going to deal with that. Triggering this kind of time-intensive hand-washing ritual is not it. I'm just going to roll down my sleeves and not deal with any sort of things that's contaminated. So these things are kind of there. As you might expect, whether it's anxiety or OCD, these symptoms cause a lot of functional impairment across life domains. These get in the way with people's academic work, when we think about students and young adults that we see, employment opportunities, slowing down work productivity, leading to loss of work, impacts social relationships. If somebody's having a lot of worry thoughts or ruminating on social interactions, they may not want to hang out with other people. It may cause a lot of distress and anxiety, even kind of having those experiences. Or with OCD, these time-intensive rituals. Well, yeah, I could go spend time with my friend, but then I'm going to lose an hour to decontaminating myself afterwards because their entire environment is not clean. As you might expect, this can really diminish, whether it's anxiety or OCD, quality of life to a substantial level. So this is something that really requires our attention and our treatment, because a lot of people are suffering with these conditions. Okay. But we have evidence-based treatments, right? And evidence-based treatments are fantastic. There's really kind of 2 courses of treatment. One is kind of cognitive behavioral therapy if you have anxiety. And the difference between cognitive behavioral therapy and exposure with response prevention is a little bit nuanced. In exposure-based cognitive behavioral therapy, you have psychoeducation, where we orient the patient and or the family to the condition that they're experiencing and our overall model of how we're going to get them better. We'll kind of build a treatment hierarchy outlining all of those somatic, behavioral, and cognitive symptoms, and then start kind of working through them and doing relaxation training to address the somatic symptoms, working through cognitive restructuring to deal with those worrying thoughts, and really exposures to deal with those kind of avoidance behaviors. In ERP, really minimal cognitive work. It's much more really much more emphasized on exposures, or exposure with response prevention, where you're not engaging in that compulsive ritual, the compulsive behavior that's alleviating the obsessional distress. Besides that, we also have pharmacotherapy. And the pharmacotherapy across the two is pretty similar. We have selective serotonin reuptake inhibitors or selective serotonin norepinephrine reuptake inhibitors. Some of these are approved by the FDA, which is fantastic and wonderful. The dosing between the two is a little bit different in how you might do that, but I'm not going to kind of go into all of that. The important point is we have two fantastic treatment options for our patients. So fantastic. We got evidence-based treatments. This is really probably the shortest grand rounds ever, right? Because now we have a problem, we have a solution. So why am I up here? Right? Besides the fact that I like hanging out and exposing people to virtual reality. So the problem from a patient's perspective, and please tell me if you guys haven't already heard this, is the accessibility of treatments. How hard is it to get into care? When we think about kind of that, finding providers who have any sort of knowledge about exposure with response prevention, exposure-based cognitive behavioral therapy, or even appropriate pharmacotherapy is really tough. Helping patients kind of navigate this is a huge challenge. So once actually patients find somebody who knows a little bit about anxiety and OCD, whether a psychologist, a psychiatrist, or other mental health provider, we have really long wait times to get in. Okay, so maybe you find a provider, maybe you get on their wait list, and your time comes. Accessing care, physically getting there, can still pose a barrier. Okay, so this is a really huge burden that we're placing on our patients. Well, are there any sort of challenges that providers experience in delivering evidence-based care as well? So Kesley Ramsey, a postdoc in my lab who's now on faculty here and through Kennedy, did a survey of exposure therapists across the United States. And basically asking them, do you have any challenges conducting exposures in treatment and any sort of challenges delivering evidence-based care? And probably we were thinking maybe a few, but two kind of general themes emerged. When we surveyed them, and it was close to 300 providers, and the text is small and I apologize, what we found is that over 94% of surveyed OCD therapists endorse some problem of delivering exposure-based cognitive behavioral therapy or ERP. Approximately 75% said patient adherence or compliance with the treatment is hard, and it is really inadequate. So what does that mean? It means when I ask you to do your exposure homework, when I ask you to leave the office and do the things that are going to get you better, a lot of times people don't. Or they come back and if you're like some of the patients that I see in person, we'll have a laundry list of homework that they did all in the exact same blue pen that we keep in the waiting room. My personal favorite is when I came up and they're scribbling everything down. I was like, oh, hey, I guess we did that on Monday, huh? And it was Friday. So they were filling out their homework in there, and that doesn't discredit them. I mean, we all kind of forget to fill out forms, but it does raise a question: did they actually do it, or are they just trying to humor me because they, don't want to disappoint me? So exposure homework adherence is one of the biggest barriers that clinicians are reporting in care. Okay, that makes sense to me. One of the other ones that I didn't really quite think about is that oftentimes patients or providers had trouble accessing exposure stimuli. They had trouble, with the patients actually doing the exposures outside of session. So whether it's patients accessing stimuli outside of the office or in the office, that was one of the other biggest barriers that they provided across the board. So being able to kind of access these things, finding those fear of heights, creating those contaminated exposures, and that was something that I didn't really expect. Some people reported that there's no challenges at all, everything's fine, and then we also got some quirky responses that literally could be a whole other paper about who kind of responds to national surveys in general. So we have those kind of treatment challenges ahead of us. But there's still one other kind of treatment challenge that I want to kind of highlight, and really the optimization of evidence-based services. So when we think about kind of evidence-based care, we talk about kind of clinical trials establishing the efficacy of treatments, having patients, perform better than a control condition, and leading to kind of a treatment response. In anxiety and OCD, there's a fair amount of partial or non-response to treatment. So think about it this way. If I ask you to invest all this time, a typical course of CBT or ERP is about 4 months of weekly therapy, right? A typical course of an SSRI at an adequate dose is about 4 months of therapy, 16 weeks, depending on the clinical trial you go by. So that's a lot of time, a lot of energy, going to doctor's appointments, paying insurance fees and out-of-pocket expenses. What if I told you, you put in all this work and you only have a 50% chance of actually having a treatment response. Does that seem like an okay deal? Not to me. Well, maybe. Ray's shaking his head. Yeah, it's pretty good. Maybe not. I mean, I don't know. And if I told you, hey, take your Tylenol and you roll the dice and maybe, or ibuprofen, you have a 50% chance of having that headache go away, we probably wouldn't all be in that same boat. It's a little bit better for anxiety. About 50 to 80% of people have a treatment response. Depending on the clinical trial you go by, that's great. That's kind of wonderful. One of the things that kind of comes up is this long-term outcome and long-term care. When you actually follow people up over multiple years, whether it's exposure-based cognitive behavioral therapy with or without an SSRI augmenting it or paired with it, relapse rates are pretty consistent, about 50% in those studies. You have about 20 to 25% that are in a stable remission from that kind of initial treatment of CBT, but most people kind of relapse even if they were a treatment responder. So the take-home point here is only about half of people, whether it's in the short term or long term, are getting better. So we really need to think about how we can optimize or enhance our kind of current evidence-based treatments. So how are we going to do this? Clearly, VR is the ultimate solution to everything, right? Oh, maybe not. We'll see. We'll see what I convince you by the end. We really need innovative solutions because what we're doing right now is insufficient to get us to where our patients are really achieving that achieving kind of remission and really wellness. So the kind of mission that we have and set out to kind of address is how do we address increasing accessibility of treatments, addressing adherence in treatment, and really enhancing the effectiveness of treatment. So I'm going to share a little bit about what we're doing here through our kind of clinical and research program to work towards these goals. How are we increasing access to care? So first and foremost, you guys may not know this, we have a small internship program in the Division of Child and Adolescent Psychiatry through the Center of Developmental Behavioral Health. So we currently have 2 interns who are getting trained moderately well. I mean, they have to deal with me, which is probably the worst part of it, but in exposure-based cognitive behavioral therapy. So we're growing this program. We have 2 right now, 2 full-time interns. We're planning to grow that. In the next year, we're also planning to establish a clinical postdoctoral fellowship where we're able to increase access to care as well, too. So part of this is really increasing access to training. So we have 2 young people, and this is our kind of first cohort of Abigail Pine, who's at the top, and then Emily Pressler, who both of them we're trying to kind of retain for that postdoctoral fellowship, as well as rope them on into research. Another way we're trying to increase accessibility and access to care for patients is telehealth. And this is something that's now become a big part of our everyday lives, right? Now when we're seeing patients, half of them are on Zoom, half of them are not, or whatever, DoxyMe or whatever kind of platform you're using. But this has now become a kind of regular standard practice. The question that I often get a lot is, well, are the outcomes the same? And now research is starting to kind of come out. A paper just came out by Marty Franklin in JAMA Open, and there's a paper by Andy Weiss in Psychiatry Research comparing both an intensive as well as regular outpatient care of telehealth versus in-person. And the outcomes, in both large sample sizes, the outcomes are pretty comparable. And I think ultimately it depends on what's going on and kind of who the best level of care is for, but you're not seeing a diminished efficacy in terms of reductions in anxiety or OCD severity based on the delivery format. So we know that telehealth can actually help a lot of people and address a lot of those barriers. That's going to increase kind of our overall provider workforce and increase the accessibility of treatment. But even if we double our provider workforce, estimates suggest that we're only going to make a modest public health impact. So there's no way we can see all the people who actually need evidence-based care in our clinical setting. So we still need to kind of think about innovative ways to increase access and care. So this got me interested in this idea through a collaboration with Kaiser Permanente because they're starting to use mobile health applications as a first-line level of care. And they have 6 mobile health applications that they've been rolling out and actually prescribing to patients and families that come through the clinic. And I asked a very somewhat silly question of, well, what are the outcomes from this? And they said, well, Joe, we hadn't actually looked at that yet. It sounds like a really nice kind of opportunity to do so. And so that's still underway, but it led me to this idea when working with Paige Segan of, well, what does the evidence say? What's our kind of benchmark? Are these kind of apps that we all kind of probably have downloaded on our phone, are we moving the needle? So we did a meta-analysis And what you kind of see from a meta-analysis across randomized controlled trials is there's a small, modest effect. So for somebody on a wait list, if they are getting an app like the Calm app or many of these other ones, you're actually going to see about a small effect size of reduction in anxiety severity. So for maybe people, if we think about a step care model, this could be one solution to help reducing our wait list. Now, is that going to kind of handle high severity or low severity? No, we don't know. The other interesting thing that we wanted to explore engagement with apps and see if that was a moderator of treatment. Just for an aside here, think of how many apps you guys, has everybody downloaded the Calm app or any other mindfulness app on your phone? Don't actually raise your hands. How often do you access that app? You might use it once or twice, but it's not as common as you might think. There's even somebody who gave a research grand rounds presentation, I want to say 2 years ago here on sleep. And they had this really massive digital mobile health trial to improve sleep outcomes. And they had 300 people enrolled to the active treatment and the control treatment. And then they had 150 people drop out, and only 30 people completed the study. But amongst the treatment completers, things went really well. And they were talking about how these outcomes were really wonderful. And then I was like, well, what do you mean about what happened to all those dropouts? They're like, well, we don't know if they actually opened the app or not. And we couldn't really follow them. So we also don't know a ton about app engagement. And I think that that's another important piece that we need to kind of address. How do we increase access to exposure stimuli for providers? Well, I think first and foremost, something that you guys saw, and hopefully we'll be able to experience a little bit later, is virtual reality exposures. Now, I know you guys are thinking, clearly Joe is at the forefront of this and has been doing this for forever. There's been people who've been doing this way before him. But they've been doing it in clinical settings using really clunky technology and really, really poor graphics. And even with that clunky technology and that poor graphics, it's shown a lot of promise for specific phobias and PTSD. More importantly, when we surveyed those kind of exposure therapists across the nation, almost 85% of them actually said, hey, I'm interested to learn more about VR. And then we said, well, have you used it or what do you know about it? And only like 10% had ever used it. But it's a cool toy. It's a cool technology. It's something we can bring into care. People just don't know how to use it. The one question we got across the board is, well, but I don't know, because are they just as good as real-world exposures? Is putting Nathan in that elevator just as good as kind of dragging him up that elevator? We won't actually make him walk the plank, nor will we do that. But are they just as good? So we start to test this out in kind of both anxiety and OCD. We did a preliminary test in a handful of kids, and the paper is out in Child Psychiatry and Human Development. And we just wanted to see, can these exposures, if we treat somebody with a specific phobia, something that these things are meant to kind of do in kids, are we kind of, one, helping these patients get better? Two, are kids actually interested in doing these exposures? And three, and this is the important one, when somebody's interacting in this virtual environment, are we seeing that kind of same increase in subjective units of distress or SUDS? Are we seeing that same increase in psychophysiological responses and that habituation curve? Because if we are, then we're actually seeing that these virtual exposures are doing the exact same thing and performing the exact same way as real-world exposures. So when we kind of completed this study, we found that VR exposures were feasible. Nobody said, no mas, no more, we can't do this. And we're acceptable. Most patients and kids really enjoyed doing VR work. We had a few kids who were like, well, can I spend more time doing the spider exposures, which I've never had a person do in real life. But they wanted to play around. How did it perform when we actually look at that kind of physiological and subjective responses? We see that same kind of level. We see that same kind of arc where at the start of treatment, somebody says, oh, this might be a 6 out of 10. We see it increase to an 8 out of 10, and by the end they habituate or they acclimate to the exposure, and they're down at a 2 out of 10. Same type of curve on physiological responses using skin conductance response. So you see that nice kind of habituation curve over the exposures. A modest reduction in anxiety, nothing major. And this is mainly because we're doing specific phobias. A 1 3-hour session type treatment is a proof of concept. My suspicion is over time we might see a greater reduction, but maybe not. So we put that paper out there. And then the next question is, well, they look the same, but what if you do a head-to-head comparison? Are you actually going to see them perform the exact same way? Because there could be variability across people. So we designed another study that we're doing in OCD, where we actually have people do an initial screening assessment to make sure they have both contamination symptoms, checking symptoms, which we know come along in OCD, as well as symmetry ordering symptoms, so making sure things are lined up just right. And we built a virtual room that parallels our exact waiting room with all those exact same things. And what we do is we have them come into care and randomize them to either do VR exposures and then fill out paperwork and then in vivo exposures, and then come back the next day and repeat it, which allows us to kind of see, are we seeing change over time, and are we counterbalancing? Is this just due to an ordering effect? The trial's going on right now, and a big shout out to Nathan and Amy, who are kind of key people on this study. And what you start to see is there's a comparable pattern of physiological and subjective responses to both the VR exposures and the in vivo exposures. So you're seeing that nice kind of increase and decrease in that habituation curve. Fantastic. One thing that I want to highlight, and we only have a handful of participants through the study, we're aiming for 30, so feel free to send us kind of kids and older adolescents with OCD. But one thing I want to highlight is you actually are seeing greater physiological arousal, those two in vivo exposures. So VR exposures are not necessarily, eliciting that same level of physiological reactivity, but still a decent amount, much more so than kind of baseline. The thing I want to highlight is everybody prefers VR exposures. Kids view this as an engaging modality. So, if I'm trying to kind of drag, a son, a daughter, a patient, a family friend into therapy, it's a lot easier to hand them a headset than it is to actually try to drag them and do those exposures outside a clinic. What about increasing adherence? So we have kind of increasing access to stimuli for providers. We give them a VR headset and a few other kind of things. Can we actually make adherence a little bit better? So exposure homework, and really homework in general, is a fundamental problem. I want you to think about, if you guys have kids, nieces and nephews, how often do kids, adolescents, even young adults want to do homework? If you guys are educators, think about all the homework you assign. Does everybody do it? No, right? Unless you have a perfect group of folks, in which case, fantastic, you are amazing. Homework is hard, whether it's in the classroom, in therapy, or at home. So how do we kind of help people get better? Well, clearly VR, and I forgot about the whitewash, that is a VR headset. Clearly virtual reality is a solution that's going to kind of make everything better, right? I would love to say yes. Everybody's different. Everybody's exposures are going to be different. If you're treating specific phobias, those fear of heights will be fine. For OCD, what's going to be contaminated for one person is not going to be contaminated for another person. So we could either spend a lot of money to build individualized exposure rooms for people, or we need another solution, right? So going back to that survey where we kind of wrangled all those exposure therapists across the nation, over 50% of them reported already using some sort of mobile health application in their care. And a lot of it was kind of recommending mindfulness or daily affirmations or other stuff. But it got us interested in this idea, can we start to use mobile health in care, and how to do so, particularly to address adherence. So you need something that's a HIPAA-compliant platform, right? First and foremost, if you're going to exchange communication or document anything, you want to make sure that it's HIPAA protected. And there's a product through a company called Virtually Better that was funded by the National Institute of Health when I was at UCLA. And it was called OC Go. It came out around the same time as Pokemon Go. And clearly scientists are very good at coming up with names and marketing. But I think it highlights that scientists don't know necessarily how to take products to market. But what you could kind of do in this, it was funded through an SBIR or STTR grant, but you could actually create multimedia exposures and document those exposures and start to kind of make sure, like, when those exposures were done, that information was documented and pushed back to the kind of parent or the clinician. So you could kind of ask somebody to mess up their books on their desk for 10 or 15 minutes or 10 or 15 seconds, take the picture beforehand, take the picture afterhand, and then it's documented. Now it's not questioning, is it being done in the waiting room? It either happened or it didn't. And what time was it done? It allowed for asynchronous completion. So kids could do this, parents could do this at any time of the day, and you're not getting stuck. It's not kind of these constant reminder prompts. And what we wanted to do is actually test this in a small clinical trial compared to paper and pencil methods, because that's pretty much what we do. That's the standard of care at this moment in time. So as part of that R41, R42, we conducted a brief crossover trial with my colleague Peter Turk and John Passantini out at UCLA. And we compared the mobile health application over an abbreviated treatment period, so about a period of 6 weeks of ERP versus paper and pencil during that 6 weeks. And then we said, well, what if we gave them the app afterwards? Are we seeing greater increase in exposure homework? Really focusing on exposure homework adherence, the thing that everybody struggles with, the thing that we know needs to get better. And are we seeing a greater completion of exposures between sessions? And then for those people who got that app afterwards, are we altering the trajectory of care? Are we improving outcomes? Because we know the more exposures you do in care, the better you get. So what did we find? Well, at that 6-week comparison, and this was a bit shocking, and I think this was because this was done in a university clinic setting, they assigned almost 1,200 exposures over the course of treatment. Over the course of treatment, you had about 800 completed for a compliance rate of 68%, so a little below a C, high D. With the mobile help app, they had actually about 1,000 exposures assigned, so a little bit less, but a much higher completion rate. So that kind of level of detailed compliance actually can matter for an 83% completion rate, which gave us a pretty reasonable effect size of about moderate effect size of about 0.5. Anyway, we got 22% greater adherence. So meaning that if somebody was assigned homework, you'd have a 22% greater chance of getting them to do it. What about that? So that's just after 6 weeks of treatment. If we kind of continue with it, things may or may not get better. We don't know. Or actually, we know a little bit. What about that longer course of trajectory? So we followed people up, and this is the mean scores on the SciBox, or the clinician-rated OCD severity scale. At week 6, you actually saw only on clinical outcomes, head-to-head treatment, mind you. So ERP, evidence-based treatment, to ERP, evidence-based treatment. At week 6, a small effect size. By week 12, the difference starts to get larger. If you also look at week 6 for that kind of green group, where they started off with kind of the paper and pencil, you see a dramatic change in the trajectory of treatment after the app is started. Well, we talked a little bit about how to get people to wellness, how to get people to remission. What are the remission outcomes? Does doing more exposure homework actually matter and get you better? And this is a small trial, 30 people overall, 27. 23% of people in that standard of care condition achieved clinical remission, as evidenced by a SciBox total score below 12, whereas over half in the mobile health condition achieved clinical remission. So we're able to actually get our people better by using these tools. Okay, so we're addressing accessibility, we're addressing adherence. What about addressing treatment optimization? How do we optimize treatment? That's the kind of biggest question, right? You know, are we going to try to target mechanisms? Are there, new treatments? Well, we know for exposure-based therapies, we know that there's associative learning processes at play. We know associative learning processes are impaired in kids with anxiety and adults with anxiety disorders, as well as OCD. This has been documented across the board. The specific impairments are going to vary a little bit based on disorder and based on condition, but they're there. So a while back, there was a big interest, I want to say from 2008 until about 2014, 15, in augmenting exposures with D-cycloserine. And this was going to be the kind of solution. We're going to optimize treatment by enhancing this associative learning. And if you guys read those articles, all the initial studies looked great. And by the end, not so much. So just taking a one-size-fits-all approach isn't going to kind of work by augmenting learning. Well, then in 2014, as the DCS train kind of started to kind of dwindle down, there became a big interest in this inhibitory learning train. And if you guys aren't familiar with inhibitory learning, I've had the pleasure of studying it for a long time, and it took me a long time to actually understand it, which means probably something more about me than the concept. But basically, we have one kind of associative memory and another one. So we have if I touch this contaminated coffee cup, I feel that physiological reaction, and I feel that distress, and that's kind of one memory. In exposures, we're trying to build another memory where I tolerate this and I know that nothing bad is going to happen. I'm able to do this, I'm able to drink, and there's no terrible outcome. With exposures and inhibitory learning, we're strengthening this other memory to block that initial fear memory. That's the kind of fundamental piece. Years of graduate school life to get to that 2-minute summary. I wish I could go back in time and tell myself that. Saved many, many articles of reading. So now there's an interest in optimizing inhibitory learning. I think there's some potential to that. And the way you do optimize inhibitory learning is, well, I want you to tell me your biggest, greatest fear, what you think that terrible outcome is going to be, and we're going to do that. Now, that might work for some people because we're going to maximally violate that kind of threat expectation. That may work for some people. If we had a patient and we were doing a patient interview in here, and I said, we're going to pick your biggest fear and we're going to maximally challenge it, what might happen? Right. So the patient may be like, I am out of here, good day to you. I thought flooding was a thing of the past. And I think it's hard to kind of, implement in practice. I think there's some variability in there. But this is not also going to be a one-size-fits-all. I think there's modifications to it, and it's more than just inhibiting fear memories. It's building distress tolerance. It's attentional control. These kind of one-size-fits-all approaches may not work for everybody. So how do we kind of deal with this? So I got interested in this idea of the heterogeneity of symptom presentations amongst our patients. Whether you have anxiety or OCD, there's some commonalities, but patients look a little bit different, right? And that's why we try to meet patients where they're at. Particularly for OCD, I did a bunch of papers looking at symptom dimension response. Do specific OCD symptoms actually get better and are more responsive than others? So things like contamination cleaning or symmetry ordering might do a lot better than hoarding. Makes sense. So we know symptoms can matter for some conditions. Well, what if somebody has more symptoms in one area than another? Can we actually take this information and personalize treatments? Well, it's a little bit hard to do if you're taking this kind of absence-presence approach, but what if we take a more dynamic modeling approach? What if we try to kind of model somebody's symptoms over time? Could we do that? And would it lead to kind of better care? So can we take something like ecological momentary assessment? And are you guys familiar with EMA? Perfect. So, you can download an app on your phone, and my phone's up there. I should have had it up here for this. And download an app, and we can kind of push out symptoms and have you make ratings on them over time. And we're doing this right now with the support of a Catalyst Award from Hopkins, where we take the most common kind of symptom domains on the SciBox, YBox, ask people to rate them. And then also take a look at things that we know are important in OCD, like fear, not just right sensations, doubt, intolerance of uncertainty, to start to model what individual patients' symptoms kind of look like. We build and we develop ideographic network models of each kind of patient and really start to create these personalized symptom networks that really can kind of guide and improve care. So what does this kind of look like? Because it took me a little while to understand this as well. So in standard, this is an example of an ideographic, individualized patient network model. So this is somebody who has contamination, cleaning symptoms, some somatic health worries, is worried about intolerance of uncertainty. What you do in kind of standard clinical practice is we would build an exposure hierarchy, a symptom kind of checklist of what's going on in care. And we'd ask them to, nominate the symptoms, is this an 8 out of 10, 5 out of 10? Once we start doing exposures, and the person may nominate some superstitious behaviors. It's around Halloween, there may be some more of those. They're throwing salt over their shoulder to get rid of bad thoughts. I can't step on a crack, or I have a black cat that I can't cross. We may target this kind of area on there in that red box that's not relevant, really not a kind of central part of the kind of patient's kind of network, versus these contamination, cleaning, disgust, and fear-based symptoms that are really holding these networks together. So if we target these kind of core nodes, what we can actually do is disrupt symptom networks that maintain pathological behavior. So we're running a small clinical trial right now in kids with OCD. So what does this kind of look like? And Lexi's coordinating the study overall. This is an example of a single patient's data. The green lines are correlations or residualized partial correlations about 0.3 or above. The yellow ones are 0.2 and above, and the other ones are 0.1 and below. So you see there's some big kind of areas where there's these core symptom nodes that we want to target with exposures. Once we actually apply this, does this work And you see those networks are starting to get disrupted. We're not trying to disrupt all the networks in this clinical trial. We're actually just trying to see if we can change and diminish that overall density. And what you're starting to see here on the right is we can. So this could be a potential model of ways to kind of disrupt symptom networks and help people achieve wellness in a bit more of an efficient and effective way, rather than adding on a whole new thing and being much more personalized to our patients. So hopefully I've started to kind of convince you guys and get everybody thinking that really a path forward really does exist. A path forward to improving access to patients and providers here at Hopkins, improve adherence to treatment, and really we can start to kind of optimize our outcomes on a more personalized, individualized patient level. You know, that all being said, there's a whole mountain of research that we still have to do. How do we kind of, for whom is VR better? Personalizing care is really important. How do we kind of bring VR exposures into the clinic and kind of dissemination and implementation approaches? So we haven't figured it all out yet, but hopefully the next time I get dragged up here, I'll have more answers along those lines. So I appreciate your time and attention. Thank you. Do you want this one?
Thanks, Joe. Really interesting, and you make a very compelling case. The fact that, of course, adherence to treatment is so low is important. But, you know, I want to ask you a question about one thing you said, and that was that I think you said physiologic responses to VR are less or lower, which intuitively makes a certain amount of sense. When I tried your goggles once before, they were really pretty astonishing, and I do have a bit of a fear of heights, and I was pretty terrified when I saw that elevator open up. But I don't think it's it didn't feel like it'd be as intense as the actual real life experience. But my question for you is there any evidence as to whether or not there's a sort of threshold effect? In other words, you could imagine it might take a certain level of arousal in order to create change. Or conversely, is there evidence to the contrary that even at lower levels of arousal, if you do it enough times, you make headway?
So really great question. The best literature or the best kind of evidence comes from PTSD. So I didn't talk about post-traumatic stress disorder here, but there are some really immersive and great experiences that are available. Skip Rizzo is kind of leading this pioneering work out at USC. And they've done a lot of cool stuff that's not accessible unless you're part of the DoD or their specific work group. Their virtual reality exposures for PTSD are quite immersive. And even in those general experiences, they actually translate into real-world clinical outcomes. So people are able to go from having trauma related to Afghanistan and Iraq and be able to go back there without any sort of trauma symptoms. So, I think the question is, going back to your point, it kind of varies, for whom and for what. I think with PTSD, oftentimes there's greater autonomic arousal. With specific fears, this is for the initial study, we're looking at kids for this one with VR, where we're comparing VR exposures to in vivo exposures. There's also, these are kind of young people, so their physiological arousal may not be as great as young adults or older adults. So I think we have a lot more work in this area. We're also probably one of the few people, Nathan, when he was bringing over the headset and setting stuff up, was like, well, should I bring our physio equipment too to show everybody? And I was like, no, we're not going to hook everybody up because it's time intensive. So when people are pushing this stuff out, there's not as much kind of physiological reactivity. People aren't being as kind of mindful about this as they should. The other piece to add is most of this stuff is now been brought up by proprietary companies. So a lot of the VR exposure suites that you could get, now you can no longer get. Or they're being pushed out by companies on a single-use headset. So is that really dissemination and implementation savvy? No. Like, you're not going to buy a single-use headset, just using it for that. You want something that's going to be an app that people can download, because probably a chunk of people in this room may already have an Oculus Quest or two, looking at people and just prevalence rates. So this way, then they can actually access the app and do their homework in a way that's much more engaging and do it from the comfort of their own living room. So,
Thanks. Other folks have questions. Dr. Scharf.
right. So the question kind of was, can there be maladaptive or unintended consequences to using technology? This has come up a lot with screen time use. There was a podcast webinar that I did with Brad Schlager last Wednesday, and Brad is the CEO of Kennedy Krieger, on screen time use. And are screens bad? What do you guys think? I mean, we got a couple people on screens right now. We're watching stuff on a screen. And I say that jokingly, but it's true. This is all a technology. Whether it's a phone, whether it's a VR headset, whether it's a laptop, a screen, telehealth, in technology itself isn't necessarily inherently bad. I think it's how we use it. And one of the things in VR that we're studying is kind of unintended side effects. Our kids getting sick, our kids spending too much time. I think that there's more research needed. We haven't seen kids go above and beyond. It's, they want to play around with VR a little bit longer, but it's not like anybody is like, oh, let me do more exposure homework. I think what we can do is actually start to gamify interventions. And now that kind of CBT homework or ERP homework can actually be fun and engaging. Now you can kind of have like a kid asking mom or dad for their VR headset to do that, and we can monitor adherence in that VR headset. Wouldn't that be pretty sweet? So I think there is a path forward, but also not necessarily thinking technology is all good or all bad. We just have to monitor the safety. But great point.
Yeah, thank you. Dr. Margolis.
Just to combine those first two questions, is it possible that individuals who are really into gaming videos and the like are so used to this kind of phenomena that it has less salience and simply less effective?
So the question is, for people who have like gaming concerns, gaming addictions, will this type of modality be less effective? I don't know. It's an empirical question. The flip side, I would say, is it could be less effective, but also it could ease them on into CBT, in exposure-based therapy. So it could be a nice gateway or a stepping stone to get them into care because it is familiar. There's a now new faculty member, Jonathan Munoz, who started talking about, creating a D&D game of CBT. This has been brought up multiple times. Really D&D got popularized by
Dungeons and Dragons.
Dungeons and Dragons, sorry. In case you don't watch Stranger Things, they got popularized by this. That's how I came into it. And now you start to kind of think about experience points. How do you kind of build your character? Do you want to have them? How are you going to navigate this situation? So you can start to kind of bring these narratives into a lot of things. So I think it's, there's a beautiful power to storytelling that we can imbibe through this technology. But great point.
Thanks. Dr. Bienvenu.
I was curious whether VR enhances compliance or adherence to homework assignments for adults variously.
That is a great question. So the question is, does VR enhance homework compliance for exposures in adults? There really wasn't a ton of data in between sessions. So how VR has been largely used prior to this is somebody comes into the clinic, we do our exposures, and then they leave. What we're now starting to kind of realize is most of that exposure time happens between sessions, right? Most of, you spend an hour, maybe 2 hours a week in therapy, but really there's like 72 hours when you're awake where you could be doing exposures. So I think that's a really important study that we should probably do. So we have also used some VR in the hospital setting too with Therese Canaries for blood draws in the pediatric hospital. So I think there's a lot of potential to make therapy and exposures a little bit more fun.
And, oh, yeah, go ahead. Dr. Reynolds.
Kind of going on the same topic with the virtual reality being preferred, is there any way to assess
No, right? And it's so the physiological arousal piece. So great kind of question. Is it less preferred because it's less physiological arousal? It could be. I think we need a bit of a large. So I don't want to say this is a panacea and going to solve everything, because I think too often, Jimmy had a really nice paper on psilocybin and psychedelics with David Yaden, and we kind of see these things go through this kind of burst. I think that could be a possibility, but also I think kids are more excited and engaged. And if I tell you you're going to do something, it's going to seem a lot more scary, versus playing a video game is something they're used to, so it may not feel as real. Their SUDs are still going up, so they're interpreting it as real, and we're still seeing some kind of interest or physiological arousal there. So I think the question is it real enough? There's a paper of social anxiety that somebody put out in Canada, and they compared VR to real-world exposures, to starting off with VR and then real-world. And it was a pretty small study, like 20 in each arm, in which you actually saw that people who got VR in real-world exposures, the combination actually did pretty well. Patients subjectively reported it's a nice stepping stone. So I think longer-term care might be, going back to Russ's point about people who may be a little bit more hesitant or kind of may be more used to gaming. This could be a nice way to reduce some of those barriers and increase access to care.
Good point. Other folks?
I think
Dr. DePaula. Oh. Dr. Nestat.
I just have one simple comment. I just wanted to compliment you on the work you're doing and the presentation. I don't know whether this group knows how difficult it is to identify a therapist in the community for exposure response prevention. It's just impossible. And this is a metropolitan area with great academic universities.
And
Why that's so important.
well, thank you for that acknowledgement, and I think it really highlights the first part of what we're doing in increasing access to care. 2 rows in front of you on your left, we have Abigail Pine, who we dragged on over here to do her internship, and then it's really starting to kind of grow that so we can increase accessibility to patients and families, because it's hard. It really is.
Dr. DePaula.
Yeah, thanks. I wanted Dr. Nestat to talk about his experience with Isaac Marks. And really, the question I'll ask you is just to flesh it out. How long does the exposure need to be? And what is the physiologic basis for that?
So great question. How long does the exposure need to be, and what's the physiologic basis for that? So typically, and I would say it goes based on kind of approaches. So from my perspective, we're just trying to see with VR, are we eliciting that response, and does it go down? In real world practice, one of the other things we developed is, so we don't have an empirical answer to that question, first and foremost. One of the studies that was not yet funded by the NIH is actually asking, is subjective report of physiological arousal, is subjective report or physiological arousal a better measure to determine when an outcome is done, when an exposure is done? And we can kind of collect both using simple sensors like a heart rate monitor, skin conductance response, and your cell phone. So we developed, some ways of doing that. Short answer is we don't know what we don't know, but hopefully the R34 will be accepted on the 3rd submission, and I'll have an empirical answer for you.
If there are no more questions, I think we'll transition into the next phase of this, which is that folks who want to take off are free to take off, but Joe is going to have a live demonstration for people who want to experience the
Provided that you don't have a
fear
fear of heights. Provided you do not have a fear of heights.
But let's give him a round of applause. Thank you.
Thank you, guys.